Good morning, good afternoon, and good evening. Welcome. My name is Stephanie Mullen. I'm the project director for TBDIA. Thank you all very much for joining us today for our webinar on practical considerations for a country that is transitioning its TB surveillance system from a traditional paper-based model to a digital system. We're very happy to have you here with us today. And I'm just going to pass it to David for a quick note on translations. David?
Thank you, Stephanie. Again, a warm greeting to all of you that have joined us. I'm David Johnson, the project coordinator for TBDIA. And I just want to briefly note that this webinar is featuring simultaneous translation into Russian. So if you are a Russian speaker and would like to enjoy that translation, on your Zoom toolbar, you will see a globe that says interpretation. If you'll click on that globe and then click on the Russian channel, you'll be able to receive the Russian translation. Thanks very much, and back to you, Stephanie.
Great, thank you, David. And just a quick summary in case you're new to our project. TBDIA is a global 5-year cooperative agreement, one of the first projects funded by USAID to support their global accelerator to end tuberculosis in 2018. TBD is an associate award under the Measure Evaluation Project. Measure was a 20-plus year project to strengthen health information systems, including TB. TBD's overall strategic objective is to ensure demand analysis and use of TB data to inform national TB programs and USAID interventions and policies. Next slide, please. TBD has 3 result areas that are intrinsically linked. We support national TB programs and their partners to strengthen the collection, analysis, and use of TB data, to improve performance-based monitoring and evaluation frameworks and information gathering processes, including new tools and methodologies, and to strengthen reporting and communication practices to address knowledge gaps and share methods, tools, and approaches, making sure data is being packaged and communicated in a way that can be easily digested and used by a wide audience. Next slide, please. The next 2 slides show the global work we are currently undertaking. These activities fall into 6 work streams: performance-based monitoring and evaluation framework, assessment tools, country engagement, communications, our TBDIA website, which includes the knowledge and data hubs, and capacity building. Next slide. Our suite of tools, data, and other resources can help at any point in the TB M&E and surveillance process. Taken together, they provide a holistic view of a country's TB M&E and surveillance system. These tools are available on our website, tbdia.org. Next slide, please. We are working in USAID's 24 priority TB countries highlighted on this map. We also receive additional field funding to respond to direct requests from countries. Currently, we have field funding from the Kyrgyz Republic, Uzbekistan, Cambodia, DR Congo, Nigeria, and the Eastern European region, which includes Armenia, Azerbaijan, Georgia, Moldova, and Ukraine. Each scope is different, but the common themes are to improve integration and enhance access to existing TB data platforms, strengthening M&E capacity of staff involved in collection, analysis, and use of TB data. Next slide, please. Just a few quick housekeeping items. We'd like to start by inviting everyone who's here today to let us know who you are and where you're from, what organization you're with, and what country you're in by putting a note in the chat if you haven't done so already. And please use the Q&A feature for your questions. That will help make sure we're able to answer everything either in the session today or in written follow-up afterwards. You can ask a question anytime, and we'll answer your questions during the Q&A period we've set aside at the end. This webinar is being recorded, and a link to the recording and the presentation will be distributed after the event by email. And I'm now going to pass it on to Meredith. Thank you very much.
Thank you, Stephanie, and thank you all for being here. I have the privilege of introducing you to our wonderful cast of speakers today. Dr. Hassan is the Nigeria Project Director, Team Lead, and Mission Point of Contact for the TBDIA project in Nigeria. Dr. Danelia is currently a Global Fund Tuberculosis Program Manager at the National Center for Disease Control and Public Health, Georgia. Dr. Song is a Project Management Specialist for USAID Cambodia. Dr. Azim is a Senior M&E Technical Advisor for the TB-DIA project. I am Meredith Silver, a Data Systems and Use Technical Advisor for the TB-DIA project. Manioval Machapanda is a seasoned digital health expert for the TB-DIA project. And Yanira Garcia Mendoza is a monitoring and evaluation officer on the TB-DIA project. Welcome, everyone.
All right, so thank you everyone for joining. Can you go to the next slide, please? So today's webinar is in the context of this global move towards the use of digital technologies in healthcare. And these technologies are supporting innovative ways of managing the healthcare, as well as monitoring the healthcare services. And we see such digitization of information system within the national TB programs as well. However, in many, if not most of the high TB burden countries, which are the USAID TB priority countries as well, we see a use of a hybrid of paper and digital systems still in place. So in this webinar, we will share practical considerations for a country attempting to transition its TB surveillance system from a traditional paper-based or hybrid model to a fully digitized system. And for this purpose, we have invited experts from 3 countries, Nigeria, Georgia, and Cambodia, to provide their perspective towards this transition. We will also present some tested strategies and solutions that can guide a country toward a well-organized transition, and then hear about our experience from Kyrgyz Republic in using those strategies to formulate a costed plan. I'm sure in your country also, you are facing challenges of transitioning to a fully digitized system. And so we would very much like to hear from you as well. And thus in this webinar, we will be asking you questions to spark discussion about the transition process, the challenges faced, and the solutions developed as a result. You will be requested to answer 3 poll questions before each country presentations. And we will be sharing the results of these polls to see how across all the countries represented today in this webinar, we are prioritizing our focus on specific themes or domains within the context of digital transition or TB M&E system. And we obviously very much encourage you to write your comments and questions in the Q&A section of the webinar. Next slide, please. So before starting the presentation, country presentation, I would like to set the context of, context of this webinar by highlighting what is meant by TB surveillance and what is case-based TB surveillance. Please note that these definitions are adopted from WHO, which states that TB surveillance is the ongoing systematic collection, analysis, and interpretation of TB data that helps planning, interpretation, and evaluation of public health practices. This definition emphasizes the dynamic and ongoing nature of TB surveillance, emphasizing its role as a fundamental tool in shaping effective public health strategies. Next slide, please. So this diagram is a depiction of case-based surveillance system in which individual level information or information from a single case, but coming out from multiple service sources is systematically collected in a longitudinal and granular manner, such that it provides information on the entire spectrum of clinical cascade from the initial diagnosis till the outcome of the treatment. And as you can see, it connects the presumptive case data, the diagnostic data, the contact investigation data with the treatment data as well, and also transmits real-time detailed information from the service points to decision makers for their timely actions. And also is linked to national HMIS and national disease surveillance and response data system. So in this way, the case-based surveillance is relevant in ending TB because it helps to inform treatment guidelines and clinical decision-making, characterize the trends in space and time, and provides a benchmark to measure the impact of interventions. Next slide, please.
Thank you, Tarek. So with that in mind, we're going to focus the rest of our time today diving into the digitization process in multiple country contexts. And then we will round off our time by presenting a strategy towards a digital transition that offers potential solutions for countries. We'll then have time for a question and answer, and then a brief wrap up. Now we would love to introduce you to our next presenter, but first we would like to get you thinking about your specific context. We would love for you to take a moment to consider a short poll question. Our colleague David is now going to launch the poll. So when thinking about creating a digital TB surveillance system, what would be some of your key considerations? Go ahead and take about a minute to answer. We have about 10 more seconds. Okay, so as we can see the results on the screen here, we see that we have about 72% of you feel like ICT workforce capabilities are one of the strongest key considerations thinking about creating a digital TB surveillance system. It also seems like data security and confidentiality, as well as internet access, are also high priorities for this group. And then we're also seeing data integration and exchange between relevant ICT systems as being also very important. It seems some of our kind of less importance might be focused on ICT solutions being adaptable to technological advancements. So thank you for participating in that thought exercise. Now we would love for you to take those considerations into our next presentation. Dr. Hassan is going to give us an overview of the NETIMS assessment his team conducted and their learnings from the completion of that process in relationship to creating a digital TB surveillance system. Dr. Hassan?
I'll be presenting on the progress in adopting electronic TB surveillance system in Nigeria, taking a cue from the NETIMS assessment. NETIMS is simply Nigeria Electronic TB Information Management System. Next slide, please. Yeah, so just an overview for the transitioning to NETIMS in Nigeria. First of all, we realized that the National TB program started off quite early in the mid-80s, and it's practically based on paper-based recording system at facility level, LGA, and even at the state level. And that was combined with limited data use and data demand. But with expanding data coverage, data expansion, and national coverage of the TB program, there were increasing demand for data and data use at national level and state level. And that necessitated transitioning to an Excel-based data system, which was also encumbered with a couple of challenges of poor quality reporting, delayed reporting, and also affecting the quality of the data. And of course, that wasn't an efficient method of storing data. So that necessitated a transition into an hybrid system of data management. The first of its kind was the use of a ETB manager for DRTB case management in country around 2010 to around 2020, 2012. Thereafter, it was transitioning to our expanding that platform to accommodate drug-susceptible TB case management. In that module, there were several components embedded in that ETB manager, but with different functionalities. Additional to that was also the introduction of other electronic platforms, the DHIS2, which is being used at the national level as well, at the HMIS level, the GX alert system at the for the GX Gene Expert laboratories, as well as the EWAS and the EPCON tool for hotspot mapping, the ComCare tool, MATS app, and the TB-Star, which are also used for screening and case notification. This also enhance the electronic Excel-based reporting that is being used at the national level at the time. And so understanding where we are at the national level enable us to be able to having a good landscape of where we are in country with the electronic systems. We are able to program an assessment to understand the functionalities of these various platforms. Next slide. So in understanding, in creating a rationale for the NetIMS assessment, we realized that a couple of challenges were being faced by the end users at different levels that are interfacing with the NetIMS tool. One is the challenges of integration, because there are multiple systems that are in use, and these systems are not well integrated with the national central base tool, which is the ETB manager at the time. And so that created a lot of data gaps, and in terms of harnessing and harvesting data from those different sources to provide a national data architecture or repository that can be used to inform decision-making. Further to that is the challenge of data quality. Many a times, even the electronic data systems that are being used, given an example to the ETB manager, not all the users are able, because of various issues of data, electronic internet facility and other issues, there were delays in getting timely report. Even when the report is entered, there were issues of completeness of data entry. And then, of course, the accuracy of the data also, because of the devices that are in use by different end users in the field. And so that affected the quantum or the level of granularity of data and the use of that data for detailed analysis to inform decision making. Also, the encumbered with this NetIMS tool is also the fact that it didn't have a national coverage. As it were, at that time, it's also only in out of the over almost 20,000 DOTS facilities, it is at best in around less than 400 facilities in the country, which are regarded as the high-burden facilities across the 36 states plus FCT. So that gives a picture of a very limited coverage and limited its use for really managing the entire landscape. Also is the fact that because the ETB manager has limited data exchange with other platforms, at that time, there was also the integration enabled between ETB manager and DHIS2, which is at the Federal Ministry of HMIS level. But then there were irregularity in the data exchange between these two platforms. So that also really was a major challenge that the system faced. Also, very importantly, was the suboptimal data use. Like I did mention, all of these other factors, essentially data quality, integration, limited coverage, affected the use of the data in this platform to really enable programmatic decision making at the national level and even at the subnational level as well. So looking at this, it necessitated us doing a very comprehensive assessment of the various electronic systems that are in use at the country level at this time, before evolving into a new electronic system that can serve the need of the country as a whole. Next slide. So in this slide, we just give an overview of the different electronic systems that were assessed or that were really used within the TB space. They all have their different uses and their different level of scope. Like the ETB manager, the DHIS2, the EWOS we noted, and even the GX alert had a national coverage in terms of geographical spread across the 36 states and the FCT. Now, because the country Nigeria is actually divided into states and the Federal Capital Territory, so we regard it as the 36 states and the FCT, Federal Capital Territory. For the ETB manager, like I did mention, was the major tool being used by the National TB Program with very comprehensive architecture meant to really serve the entire different units within the TB space, within the National TB Program. And it's supposed to be integrating adequately well with the DHIS2 that is situated at the HMIS unit of the Federal Ministry of Health. But that linkage is, like I did mention, was very ineffective. The MATS app was also limited in scope. The MATS app, the TB Star, and the ComCare are limited in scope, as you represented here. These tools are used basically for screening at the health facilities and case notification. Whereas the EWOS and the EPCOM tool also are used for hotspots mapping to aid community activities in identifying where to prioritize active case finding for case in the country, in the various communities where it has been deployed. So these are very great tools that are being used in country. Next slide, please. So when we did assessment, there were key findings that really were very significant and were really informative to guide the future planning of what the country should be looking at in evolving and thinking for a more robust electronic system that can better serve the need of stakeholders and the National TB Program as a whole. One of such key findings is the fact that for different platforms, we looked at the devices that are being used to manage those systems. Many a times for the ETB manager, tablets were provided rather than the use of personal telephone devices. For ComCare tool and the other ones supported by the partners, we realized that they were provisioned using the personal mobile phones of the individual partners without encumbering the program in procuring tablets for these end users, particularly in the private facilities or the facilities that are supported by these partners. So also we realized that the GX Alert users is provisioned on the desktop computers that are in use at those GeneSpark laboratories. There were also the concerns about the human resource capacities available to support these platforms. More importantly, for the ETB manager, it is really encumbered with challenges of having adequacy or non-availability even of support systems like a system administrator, the system software developer, or health informatics. Even a database manager was not even available to support retooling or updating the platform as need be to be able to troubleshoot the system when the need arises. And so this necessitated them outsourcing such services to external consultants, which are even difficult to find most of the time, and they are not readily available to meet the emerging needs that the program was facing. Also, there were also concerns about the functionalities of the ETB manager. Why the system was built to really be very broad strokes, to be able to have different modules to be able to update. At best, the users are unable to really fully optimize this platform. At best, we are less than 50% of its usage in terms of the functionalities that are embedded in that platform. Also, like was observed, there were challenges even generating custom reports. And when the reports are even generated, the data, the reports also have validity issues as well. So it limits its effectiveness and the usage of those data generated from the platform. Also, it was also observed that in terms of technology used for deployment of the ET Manager, it was built on a Struts framework, which is quite outdated. And also, though it's it's actually an JBoss application server, which are actually outdated tools for the current age. Similarly, we realized that though it's actually built using the Java and JavaScript, that is also very commendable. But for the other tools that was also assessed, we realized that the EWOS and the EPCOM tool, they are also very smart too and supporting hotspot mapping, like I mentioned. For the maths and the TB star, they have overlapping functions that could really be merged together, or either of the two. Either one is scaled down and the other one is scaled up as it is now. So the decision that was eventually made was to scale up MathStar and decommission TB star. Now, also, we also face other challenges that was observed with ET Manager, with compatibility issues or ability to integrate with other platforms, and also the unique functions of the ET GX Alert in working very effectively in integrating and exporting data from the different GNexpert machines to the various platforms and establish dashboards. Very important thing to note in evolving a new platform is the ensuring that the system has data security function, because for the ET Manager, it was observed that the SSL certificates are not actually in place, and that could really make the data very vulnerable on the long run. Next slide, please. Next slide. This is almost getting to the end. Yeah, so in terms of the recommendations that were made, before that, yeah, we did recommend that there is need to really optimize the ET Manager functionality, make it more robust to be able to integrate with other platforms, improving this data security on the app, and also ensuring that when new apps are developed, they are also provided with user accessibility testing to ensure that the users at the end level, at the various levels are able to have a better satisfaction in the use of the platform, and also ensuring that the platform is able to integrate with any other platforms that are in use in the country, so to be able to harvest data as a data repository. The last slide to round up this phase. So we also recommended that to mitigate the challenge of human resources, it is also important to establish a health informatics community for the TB program that will serve as a critical mass to be able to review and support the routine management of this data digital system interface and the evolution of new platforms that may be brought into the country as a way of safeguarding the quality of the data, integrity of the data, and data confidentiality as well. And then to develop a roadmap for evolving a new case-based data electronic system that the country really wants to have. Over and thank you.
Thank you, Dr. Hassan. Now we're going to introduce our second poll question for your consideration and thoughts. What governance structures and processes would you ensure for implementing digitized TB surveillance? Again, think through your country-specific context in terms of governance and take about a minute to answer. We have about 30 seconds left. Okay, David, if you'd like to launch the results. So it looks like about 80% of you really feel like that government buy-in for digitization is an important governance structure and process for implementing digitized TB surveillance. I'm also seeing arranging necessary ICT infrastructure. Again, this seems really important, especially and cross-cutting across domains, as well as reducing data collection and reporting burden on healthcare workers. It seems that some of you might feel managing multiple players and ensuring compatibility with international standards are a little less of an important focus in this, but I do see that about 51% of you feel that engaging private sector is important. So thank you again for that thought exercise. And now I would love to present our next presenter, Dr. Danelia, who is going to share relevant experiences and learnings from Georgia on the role of TB data governance in the digitization process of Georgia's HMIS. Dr. Danelia?
Greetings, everyone. I will present Georgia's recent experience of developing a fully electronic health management information system, which we believe is a significant step towards improved patient care, program management, and surveillance. Georgia is a priority country for TB control interventions in WHO European region due to still high TB burden, although the incidence is declining. To ensure access to care and good geographic coverage, there is a TB care site, so-called basic management unit, at each district of the country. This is also a starting point for TB recording and reporting. Next slide, please. We haven't started from scratch. Georgia used to have mixed type health management information system with initial recording and reporting on a paper-based forms. The TB case data were recorded in the logs, transferred to the reporting form, and sent to the regional level to be entered in the electronic database. Individual level data are then aggregated at the central level, compiled and reported. Next slide, please. And information gathered this way was quite comprehensive and reliable due to well-established process of regional and central supervision provided by the dedicated staff. The data quality is ensured through the following. First of all, it is a supervision process. There is a supervision checklist that includes detailed variables covering every TB programmatic activity and is completed at each visit per facility. Data validation occurs across various data sources: TB paper-based logs, laboratory registers, the National Center for TB and Lung Disease database, random individual treatment cards, and patient and doctor interviews. At the same time, the supervision checklists from each facility are entered into the Excel spreadsheet for further analysis at regional or country level. Next slide, please. Time lag represents one of the major weaknesses of the paper-based system. The data from basic management units are transferred on a monthly basis, and thus real-time information on patients currently on treatment that are often needed for management decisions is limited. In addition to being time-consuming, it is potentially an error-prone activity. Besides, some data, such as presumptive cases or contacts, are only registered in the paper-based log and not entered into the electronic database. The electronic database itself was developed more than a decade ago and cannot reflect the changes in the program, for instance, new drugs or diagnostics. Next slide, please. One more. One next, yes. The Ministry of Internally Displaced People, Labor, Health and Social Affairs of Georgia has prioritized the use of information technologies to streamline data systems, including those for TB, and with Global Fund support, initiated development of a new TB health management information system, enabling provision of real-time, reliable, and comprehensive data. We aim to preserve the data quality, but improve efficiency and business processes. Next slide, please. The process started from the country dialogue initiated by the National Center for Disease Control and Public Health and led by the ministry. National TB program in Georgia is a model for public-private collaboration, engaging all relevant healthcare providers. I will describe the main stakeholders in the next slide, just to mention here that all of these entities assigned a representative to a task force that would meet on a regular basis for making initial decisions and then follow up during the implementation. Roles and responsibilities of the group members were formally defined. WHO technical support was requested to evaluate the existing system and suggest optimal solutions. 3 options were discussed: upgrade the existing database, adapt DHIS2, or develop a new system locally. Based on the communication with the developer of the existing system, it became clear that upgrade was not feasible. Compatibility of DHIS2 with other e-health modules in the country was questionable, so it was decided to develop locally a new system by Information Technology Agency. Information Technology Agency is a government entity operating under the auspices of the Ministry of Labor, Health and Social Affairs of Georgia. The aim of the institution is to streamline the development and continuous refinement of the digital solutions that serve the purpose of the improvement of health, labor, and social conditions of Georgia's citizens and other beneficiaries. ITA has not just developed the module, it is authorized and will provide system maintenance afterwards. Next slide, please. The new system is fully electronic, follows the patient pathway from identification of a presumptive case to the follow-up after treatment completion, and covers cases with active TB disease as well as TB infection. Besides, the system includes program data for reimbursement for TB services and is linked with the civil registry and mobile apps used for surveillance and video-supported treatment. Given that multiple organizations are involved in national TB surveillance, it is essential that the roles and responsibilities of the different authorities are clearly defined, including those related to the governance of data, what data to collect, how to collect, who is responsible for data collection and validation, the frequency of data reporting, and data interpretation and use. National TB guidelines and WHO guidance were used for a reference on these issues. The system is comprised of different modules and provides complete information for the main users in line with their role and responsibility. The National Center for Disease Control and Public Health is responsible for epidemic surveillance and provision of diagnostic services through public health laboratories. The National Center for TB and Lung Diseases generates information related to preventive diagnostic and therapeutic services and is responsible for local and international reporting. National Reference Laboratory provides full spectrum of tests for diagnostic and monitoring purposes, also provides quality control and supervision of other labs. National Health Agency provides service reimbursement within the state TB program. The ministry needs comprehensive data to make evidence-based decisions on programmatic issues, as well as budget, etc. Next slide, please. As I mentioned, the new system starts from identification of a presumptive case and follows the full pathway. It is linked with the civil registry and thus prevents data duplication and makes easier monitoring patients who move from district to district. Both public and private healthcare providers register the patients in this system, refer for the lab tests, receive the test results, generate treatment monitoring reports, and the same system is used for billing. The built-in analytical module will enable visualization of information, create dashboards, and support coordination, control, analysis, health service performance assessment, and decision-making. Based on routine health facility data collected from public and private entities, it will also generate indicators about outputs, outcomes, and impact for local and international accountability. And finally, the new system enabled integration of two applications that were also developed locally, TraceTB, contact tracing, and LTBI, treatment monitoring application, and AdhereTB, video-supported treatment application. Next slide, please. The system implementation started from the pilot sites. Central and regional facilities were selected to test the system in various settings. Development of regulatory documents was considered as a prerequisite, namely, a ministerial order was issued mandating electronic reporting, defining the schedule for gradual implementation and transition from mixed to fully electronic system. Personal data are legally protected in Georgia, and Personal Data Protection Service is established to monitor lawfulness of personal data processing. Therefore, standard operating procedures were developed on data confidentiality, and Memorandum of Understanding was signed between three main stakeholders: Information Technology Agency, Center for Disease Control and Public Health, and a Center for TB and Lung Diseases. The MOU had a special clause on access to personal data and their protection. The e-module itself has an SSL certificate that is a digital certificate authenticating a website's identity and enabling an encrypted connection. Orientation sessions were held for public and private healthcare facility management staff, a comprehensive training of trainers, and following countrywide staff training were provided. The implementation process has been backed out by the State TB program and the Global Fund program. Next slide, please. Based on our previous experience, stakeholder buy-in has a crucial importance for implementing a fully functional system. So utmost attention was given to identification of data requirements and tailoring to business processes for each stakeholder. Classroom training was not sufficient. Continuous support is needed. So-called supportive supervision will be provided by a team of supervisors, one for each region. And this activity will also be supported by the Global Fund. Adaptation of new technology particularly was difficult for aging healthcare professionals who are not used to digital systems and will have to change practice. Besides, at present, in the transition process, the actual recording reporting workload is duplicated as the two systems are functioning in parallel. Although we had a pilot, still the business process in some facilities as identified during the rollout were different and required the system adaptation further. And finally, several district level facilities required additional equipment and IT support. Thank you.
Thank you, Dr. Ganelia. Now for our last and final poll question. We would love for you to consider what operational aspects of TB surveillance digitization would you prioritize if your country decided to transition to a national digital case-based TB surveillance system? In other words, what are some of the main technical considerations involved in transitioning? David has launched the poll, and you have about a minute to respond. About 30 more seconds. Okay, David, can you please share the results? So it looks like about 69% of you felt that putting governance structures in places and processes in place are very important for the operational aspects of TB surveillance digitization. It seems like you would also prioritize establishing clear partnerships, agreements with defined roles and responsibilities as well. 49% of you also felt that aligning the ICT solutions to the overall business architecture of the TB program, as well as addressing the infrastructure needs for seamless transition, are also important. Okay, wonderful. Thank you, David. So now we would like to present our third presentation, Dr. Song, who will share his country's experience with the technical planning that was completed in Cambodia to prepare for its transition to an electronic system. Dr. Song?
So, good morning, good evening, everyone. I would like to share with you Cambodia experience on transition from paper to an electronic digital case-based TB surveillance system. The TB program in, next slide, please. Yeah, the TB program in Cambodia is similar to most countries. The national TB program play a secretary role for the implementation of TB program, monitor its performance, and collects all TB information to report to the Ministry of Health, donor, and stakeholder. This information is generated from a case-based system, then compiled to a secondary data based on the required indicator. The referral hospital, health center, and private clinic record presumptive TB patient in the presumptive TB registration book, TB patient in TB registration book, and close contact who receive TB preventive therapy in the TPT register book. In addition, there are yellow card and white card for patient treatment monitoring purposes. The operational district in Cambodia, we have an operational district which sometimes combine two administrative districts. TB officer use TB registration book, which compile all TB case notification from their referral hospital, health center, and private clinic to generate the report to the province and report it to the provincial office. The provincial TB office then compile the report from the operational district level and then send them to the national program. That if you look at the data verification, it's have done in all levels, including the national TB program, the operational district office, and the health facility level. Every month, operational district TB office collect and report all TB cases from their respective hospital, health center, and private provider, private clinic. They compile data, generate secondary database on standard reporting, and then send them to provincial TB office who verify and then send them to the national TB program. Next slide, please. Next, I just would like to share you how the evolvement of TB MS system from paper-based to digital health system. Before 2014, the national TB program collect data using a paper-based system. And then in 2014, the national TB program adopt the electronic TB registry, which is called eTB Manager. And that's just for only for the record of drug resistant TB from through database, paper-based reporting, and continue to be used. In 2016, the national TB program customized eTB Manager system to also include drug susceptible TB. The TB management information system is currently used at the national OD level, but not until health center level. Then in 2020, the TBMS system became the primary source for reporting at the national district level. However, they still record data in both electronic and paper-based system. This a double workload burden for operational district officer who use both systems at the same time. In 2021, the national program start piloting the connectivity system, which is the system that connect all gene expert machine. And then it had been scaled up, gradually. And this system are run parallelly with the TBMS system. So it has been create a lot of difficulty in terms of generate the information. And that's why the NTP program consider this roadmap, TBMS roadmap development, it's very important and provide a comprehensive picture to the NTP where it should be go in the future. Next slide, please. The process of TBMS roadmap development, there is two key steps in the development of TBMS roadmap in Cambodia. First, they have conducted the situation analysis. This includes the literature review, analyzing the country context, comparing the current system to the international e-health system, and examining in-country best practice as well. Next, we have the stakeholder consultation meeting, and based on this review process, we consolidate the finding to develop the TBMS roadmap. Next slide, please. I would like to share with you the summary result of the assessment. I think the table is too small, but I think it just gives you some kind of idea how this present on the assessment. There are key strengths and challenges to implement TBMS system in Cambodia. As you look at the table from the left to the right, so when we go to the right, it's meaning that it's the system is mature. So as you see that even the TBMS system, it's have been implemented almost 10 years, but the maturity of the system is still, in the early stage as well. So as you can see, there's a weakness of the government and lack of guidance on the expansion of TBMS system. There is a lack of coordination across Cambodia healthcare system structure as well. Lack of sufficient budget for expansion of the program, unavailability of the TBMS at the grassroots level. As I mentioned earlier, it's only mainly implement at the OD operational district level, but not upscale at the health center level. The lack of data uniqueness, which may create a duplication and also challenge to link to another system. There is a lack of information, communication, technology, training, and capacity building to relevant people. There is an unavailability of enable ICT workforce, even at the national level and also at provincial and OD level as well. There is an absence of motivation to the people who use the system. And there is a lack of user-friendly design of the application as well. And therefore, those weaknesses and challenges need to be addressed. Next slide, please. Based on the National E-Health Strategic Toolkit developed by WHO and International Telecommunication Union, there is 7 key priorities that TBMS system need to be aligned. One, sorry, I think Oh yeah, one is the leadership and the government. Second is strategic and investment. The fourth is standard interoperability. The fourth is legislation and policy. And then the workforce, then infrastructure, application and services. So if you look at that, the four components of that system, in order to transition from paper-based to digital TB surveillance system, we need to advocate and execute a chain management that allow leadership to buy into digital electronic recording and reporting system. This will require, can you go to the next slide, please? Yeah. That's will require developing a steering committee, as you can see on the leadership part, a clear term of reference on the strategic and investment. We need to develop employee incentive program. For example, agreement with the national TB program that if we provide tablet for data entry, they should use it to enter the data for a certain period of time without paying the incentive fee. We need to improve in-house capacity to ensure that those systems can be handled by the national program. On the policy side, we also need to come to an understand that officer only use one electronic recording and reporting system to record the diagram. Otherwise, it will be very difficult, in terms of data verification as well. In addition, we need to ensure that one system is used at the nationwide. Rollout of that system is needed. Otherwise, only one part of the country will use the system for recording and reporting, and the other is still use database. We also have to ensure that the system is friendliness. For example, if we can use mobile app, that will be facilitate the user to encourage them to use that more. At the same time, there is a need to identify the overlapping area. In Cambodia, we observe that the paper-based is still used while the electronic system is in place. And that's create a lot of burden to the frontline worker who also provide TB services and also using the system as well. We need to eliminate that duplicate system to reduce the workload burden for health staff. As the system need to connect to other systems to maximize the efficiency, there is a need to ensure that the system is open application program interface, which most people know that we call API, which can be interoperability to or linked to other system. For example, in Cambodia, to the data to Kyrgyz is we call connectivity. Lastly, we need to ensure that the system is secure and protects from loss and hacker. And lastly, we need to ensure that the internet availability to people who can use the system. Otherwise, it will be very difficult to challenge. And that's all. Thank you.
Thank you, Dr. Song and Dr. Hassan and Dr. Danelia for your very insightful presentations. And as we can see, these presentations focused on three practical aspects of the transition towards digitized TB surveillance system. One of them is the key consideration when contemplating digitization, and we saw that domestic requirements and system functionality, as well as domestic technology environment, are very important consideration for this digitization. As well as there are numerous governance challenges related to multiple stakeholders, and the electronic TBMIS adjustments as the roll out of the digital system progresses, the ICT infrastructure and policy environment, and so forth. And so to deal with such challenges and such considerations, there has to be a plan to, and that plan should be well thought out and covers all these different aspects. And as we saw from these three presentations, they focused on establishing governance structures, ensuring ICT architecture, which is aligned with TB programs, business architecture, and also allows ICT research and development, and that the investments are towards the national priority and long-term sustainability. So the question is, what countries can do about it? And one important strategy that takes into account all these considerations and systematically addresses them in an organized and collaborative manner is to have a well thought out and costed plan. Such a costed plan can help progress, help the program address operational aspects of a digital transition. And how they can do it is by establishing governance structures that I just said, and all other ICT related interventions or actions necessary for that. Considering all this that we have heard today, we think that a process that helps plan and cost activities so that the NTP and other stakeholders have a clear understanding of the investment objectives and needs can be very helpful to establish that systematic move towards digitization. And then a costing tool and other relevant guideline or guidance resources can help to guide setting up the mechanisms and processes for realizing those investment objectives. So in this context, we, like TBDIA, along with other other experts, we have developed and introduced a STEP strategy and resources. And I would like my colleague now to give you like details of this STEP strategy and resources. So I will invite Meredith to please take it over from here.
Thank you, Tarek. So we can all understand, or at least assume, that digitizing a TB surveillance system is likely a long and somewhat complicated process. After all, the surveillance of tuberculosis is one of the oldest disease surveillance systems in the world. Digitizing TB surveillance involves many factors located in multiple domains, many of which have already been discussed and shared here today. So with all this in mind, as Tarek just mentioned, in 2022, the TBDIA project developed the Surveillance and Tuberculosis Monitoring and Evaluation Strengthening Plan, otherwise known as STEP, to support countries who are working towards strengthening their TB, M&E, and surveillance systems by introducing or building out their electronic systems. The STEP can be used as both guidance as well as a tool to assist implementing countries. And at the end, countries have in hand a costed action plan for which they can use to either start or continue in the transition towards a fully digitized TB surveillance system. The STEP process is first built to gather information on the current state and provides guidance on organizing that information for analysis. The STEP encourages a variety of stakeholders woven into multiple stages of the process from the very beginning, and then gathers all those involved in a workshop to validate the analysis results, and build consensus on which parts of the analysis should become the priority actions. STEP then offers a costing tool, which helps the country organize findings into a plan, and by utilizing stakeholder engagement, allows for the cost of each activity to be recorded. So at the end of the STEP process, implementing countries have both a gap map highlighting strengths and weaknesses, as well as their costed implementation plan, which we call the costed step. Now I'm going to pass it over to my colleague Yanira to introduce you to the STEP tools.
Thanks, Meredith. So the STEP process is broken down into 4 domains: TB surveillance system structure, TBMIS enabling environments, TBMIS information generation and dissemination, and TBMIS performance, and 14 accompanying subcomponents. The STEP questionnaires are designed to correspond to each domain and subcomponent. Next slide, please. The costed Excel template facilitates the implementation of the STEP priority actions. Stakeholders are able to utilize this budgeting tool to determine which activities and sub-activities to implement first, considering the financial resources needed for each. As you will see in the next image, the template has a user guide, outlines STEP domains and subdomains. It includes a breakdown of activity cost per line item and a budget summary by objective that can be summarize all of the broken down activities. In the next image, you will see that all of the activities are included, and these are determined by the overarching objectives derived from the STEP findings, which are then entered into the spreadsheet. Related cost items are then added with the cost and cost type, and the subtotals and totals are automatically calculated in column H. And now I will pass it over to my colleague, Tarek.
Okay, thank you, Yanira. It's not Tarek, it's Manyopo. So
No apologies, Manu. Go ahead.
It's all right. So I'm going to share the experience of the STEP process in the Kyrgyz Republic. The purpose was to identify targeted technical activities in order to assist the country with strengthening its cash-based TB management information system, which monitors TB within the country. So the overall objective of the STEP process were, 1, to conduct a systematic and multifaceted landscape analysis, as mentioned earlier, of the TB MNE and surveillance system within the Republic. And the second one was to develop a concrete costed TBMIS improvement plan, which was or which is to be owned by the National TB Control Program, which is the NTP program, with the active involvement of the relevant stakeholders for its implementation. So for the landscape analysis, a desk review was conducted, and the desk review research was compiled to explain the current operating environment of the TBMIS with regard to each STEP domain, as mentioned, by utilizing the STEP tools and the questionnaires mentioned earlier. So 19 documents were reviewed. That included the National Strategic Plan, the automated information audit, the recently held automated information audit, and there were some user guides that were also reviewed for the current electronic TBMIS. And key informant interviews were conducted to gather analyze and synthesize relevant information on the landscape of the TB MNE and surveillance system, including, of course, the current TBMIs in the Republic. 34 informants interviews were conducted, mainly with members of the Ministry of Education, the National Reference Laboratory, then the Department of Disease Prevention and State Sanitary and Epidemiological Surveillance, which is the DDPSSES, and the various TB program implementing partners. There were also some direct observational site visits, namely at the Oblast TB Center. We've got the PHC TB units and the TB hospitals. And then after this, a 2-day workshop was conducted. 36 participants attended, representing a total of 9 organizations, mostly from the stakeholders I mentioned earlier, such as the NCPH and the DDPSSES and USAID. During the STEP workshop, recommended options from the landscape analysis were provided for each domain. These options were carefully identified and curated based on their relevance and potential effectiveness in addressing the specific challenges that were identified earlier and the objectives within each of the domains stated. However, it's important to note that while recommended options were provided, participants were not limited to choosing just from these options. They were encouraged also to explore, additional ideas, innovations and modifications to the already recommended options, based, of course, on their own expertise and the local context. Can you go to the next slide? So the workshop identified, so there were 2 main outputs out of the workshop. The workshop identified activities and sub-activities. 6 objectives were identified under the 4 STEP domains. These were further divided into 15 activities and further into 24 sub-activities. Some of the identified objectives included things like revitalizing the National TB MNE Technical Working Group, developing and facilitating a phased implementation plan for transitioning from the current paper-based system to the national implementation of the ETB register. One of the most important ones was to develop training programs focused on data analysis and interpretation. And then the next thing was to utilize the STEP costing template and the STEP team costed identified activities and sub-activities. So yeah, that was the main, or those were the main activities that happened within the Kyrgyz STEP process.
Okay, thank you very much, Maniovo. So I'd like to just start out by thanking all of our presenters today. We've really tried to dive deep into countries' experiences in digitizing the TB surveillance system. We also have a lot of excellent questions in the chat, and I hope that we can get to as many as we can today. We will try and stay on a little after the presentation to address a couple more that we can't get to in the question and answer, but also know that we are happy to follow up via email to continue the conversation with you all. So I'm going to go ahead and open up the question and answer now, and I'm going to start with Mariam Malik's question. Can you all, meaning all of the presenters, share your experiences on digitally transforming data coming from external and internal referral using hospital dots linkages in either of the countries? So maybe Dr. Danelia, if you want to start.
Georgia, it does not matter where the patient is diagnosed with TB. The recording and reporting starts from the point where.
Dr. Daniela, can you speak a little closer to your microphone? I'm sorry, we can't hear you.
Sorry. Can you hear me now?
That's great. Thank you.
Yes. For Georgia, the recording and reporting starts from TB care site. It doesn't matter it is outpatient or inpatient facility, private or public. We used to have a paper-based form for recording, and now we are moving for the electronic system. It means that attending physician has to register a patient in the system, and there is 24 hours time for this to be done. We are in the implementation phase now, and it is a little bit challenging because people have to change practice. When it is paper-based form, it can be done on second day or on third day when patient is already on treatment, but now there is requirement to be reported in 24 hours. Thank you.
Thank you, Dr. Danelia. Dr. Hassan, would you like to provide an answer based on Nigeria's experience?
Yes, so whether the patient is an inpatient on admission or from an outpatient, it does not really matter. The important thing is that once the patient is diagnosed with TB and is to start treatment, that patient will be entered into the facility register and then is imputed into the ETB manager or any of the hubs wherever it is being applied. So that takes care of wherever the patient is really coming from. The important thing is where the patient is starting TB treatment as of the time of his registration. Over.
Thank you, Dr. Hassan. Dr. Song, would you like to provide Cambodia's experience?
I think just to add to Dr. Hassan, I think the important is we talk about uniqueness, and if the system is able to capture uniqueness of that patient, and then there's the system can catch easily on the referral, which have no problem at all, and that's very important. That whatever when you transform from paper-based to digitalize, the uniqueness of the patient need to be identified, and otherwise it's very challenging in terms of referral. That's very important, and that's one of the key components that highlight in the 7 key priority that need to be addressed. Otherwise, you have to develop one uniqueness. Either some country use combination of name and age, but we have to work on that. Otherwise, very challenging.
Wonderful, thank you, Dr. Song. We'll move on to our next question. We've actually had a couple of participants ask similar questions, so I would love to highlight this question from Steve Justo. I also would like to ask if a prison liaison was a challenge, as our country experience is that integrating work with prisons is difficult because of jurisdiction issues. Prisons are frequent reservoirs of untreated cases in developing countries. I'll open it up to any of our panelists to go ahead and answer that question and share your experience.
For Georgia, we use paper-based forms only in prison. They are filled in manually and they're taken to the central level to be entered into the electronic system because we cannot have internet connection in the prison. But the data that are collected are absolutely similar to those in the civilian sector because the diagnosis and treatment are also similar. The only difference is we cannot have electronic reporting.
Thank you, Dr. Danelia. Dr. Hassan or Dr. Song, would you like to also answer?
It's quite challenging. I think paper-based still be used in prison. The reason is, there is some kind of restriction to introduce those data collection system in prison because of this. There is some security issues. Thanks.
Yeah, I think the same experience is here. We still use paper-based record in the prisons because of data confidentiality issues that is restricting the use of electronic system in the prison settings. So same in Nigeria, same experience here.
Wonderful, thank you. All right, we're going to move on to our next question from Elizabeth Oliveras. Have any of these countries worked to integrate TB data systems with other health systems other than national DHIS2? For example, HIV EMRs? I'm interested in the advantages and disadvantages of a siloed system. Dr. Song, would you like to start by answering this question?
Unfortunately, Cambodia have not be able to link to other systems, but we already create what we call the linkages. As I present, the linkages between the TBMIS system and the connectivity data to care, which is implemented within the TB program as well, which installed in the with Gene Expert and TrueNut machine. And that's why these systems are able to share, to transfer the data, and based on the result from Gene Expert, which no need to enter the result of Gene Expert or TrueNut into the TBMA system. And that's why it's create a lot of, it facilitates somehow in terms of sharing the data between the two systems, which no need for re-enter, for example, the name of patient, age, and so on and so forth. So that's good. I think that's more efficient over. But I think in terms of linkage to other national programs, we are not in that level yet.
Dr. Song. Dr. Hassan?
Yeah, so for now, there is no direct linkages with, for example, the HIV data platform. Major concern is because at the country, as of now, we are still yet to figure out unique identifier for each patient that can help to facilitate data linkages between the TB data system and then the HIV EMR systems. But there are discussions really going on in country to figure out that. But as of now, the two systems are still running in silos. Over.
Thank you, Dr. Hassan. Dr. Danelia?
This far, the system is connected with the National Health Agency, which is responsible for reimbursement of services. And this is additional motivation for the private healthcare providers to report patients in the electronic system. We, in addition, have plans to have linkage with HIV, MIS. However, it is still plans at this level.
Thank you very much. We're going to move on to our next question. This is from Lloyd Namukarduza, and this is for you, Dr. Song. How does Cambodia integrate the use of electronic data constellation in TB/HIV integration?
I think we have the data on, as I mentioned earlier in my response, the data of the two national systems are not yet linked. But however, as the data at health facility level, which they use both for HIV and TB program, and so those information are captured. But in terms of the system, if we look at the interoperability of that system, is still silo. I think you may not capture the. It's very challenging in terms of uniqueness, and I think currently the Ministry of Economic and Finance, as they're the one who manage the what the reimbursement payment right now, they create a unique identifier, and that may help later on to link those two systems. But so far, it's still a problem of that. I think in the future, if we discuss a lot whether we should use, at one point we should use the, what we call national identification, and that's people are talking more about whether this more, it's prone to be disclose their status to the public, and that's why it's still a discussion in the country. But I think when Ministry of Health move toward digitalization, and I think the uniqueness of the patient need to be developed, and I hope that it will be coming very soon, and it's very easy to link the two programs over.
Thank you, Dr. Song. All right, so we have time for just maybe one or two more questions. Again, this next question is for all of our presenters. How did you collect data on TB preventive treatment from healthcare volunteers? A follow-on question to that is, what platform or application was used by the volunteers, and then any challenges and lessons learned to include these data into the main TB surveillance system? Dr. Hassan, would you like to start?
Okay, so for the TB prevention data set, which has to do with TPT, there are two streams of basically what we do for now is we still use paper-based systems for TPT data collection, but within the context of a contact investigation, if there are patients that are screened and are presumptive for TB and are eventually diagnosed with TB, those diagnosed cases will become enrolled into the electronic systems and they'll be captured as such. But for those with straightforward TPT regimen, they will still be captured electronically. I'm sorry, in the paper-based form. So we are able to evolve a module within the platform to be able to capture for data on TB prevention. Thank you.
Thank you, Dr. Hassan. Dr. Danelia, would you like to provide George's experience?
It is very similar actually to what Dr. Hassan just described. The primary targets for TPT are close contacts of patients with TB, and we use a special application for that. It is called Trace TB. So in Georgia, public health epidemiologists are responsible for contacts, and they visit patients' homes, describe close contacts, enter them into the application, and respective TB specialist sees the list of people who have to show up for TB screening. If the active TB is ruled out, then they are screened for TB infection and prescribed TPT. And all of it is now integrated into the one health management information system.
Thank you, Dr. Danelia. And Dr. Song.
For Cambodia, we use both. I think that's still a problem. We use both paper-based and electronic system. But however, the contact investigation was, mandatory conduct by health center and volunteer, and the health center staff is the one who able to use the system. It's not volunteer, and that's I think that's was the pro, and I think it's also the con. But in Cambodia, is maybe more specific that they only allow health center staff to conduct those contact investigation, and when they enroll people into TPT, and then health center staff will enter those patients into the system. But in the place where the TBMS system are rolled at the health center level, so they can do that. But in terms of the place where the system are not at the health center level, they still use paper-based, and that's why, scaling up the system in every health center is very important. So I think that's very important key point. Over.
Thank you, Dr. Song. All right, I'm going to go ahead and share our contact for TBDIA. We really appreciate all of you and your questions and your participation. And we would love to further engage with you offline via email. So please reach out to us. We are at hub@tbdia.org, and we can continue the conversation there. I think we will also stay on for probably just about another 5 or 6 minutes to answer any other pertinent questions. I know we did not get to a lot of the questions today, but yes, thank you again.
Yes, and so thank you, Meredith. For those that would like to hang back if your question has not yet been answered, or if you have a different question, please feel free. You can raise your hand at this moment, and we will give you the opportunity to speak. Thanks.
Okay. I will open up to any of our panelists if you would like to answer a specific question live, to go ahead and do so.
I think can I answer one of the
Yeah.
question, which is the most challenge? I think one of the most challenge is to when you. I think the example of Georgia is very important. Which most of the country, when you implement the digital platform, because the national program feel reluctant to use only one system, and then I think that's the most challenging, as they've already used, and what they fear is that they're afraid of lost the data, and that's the most challenge to eliminate the paper base while we have the electronic one. And I think we need to have a clear roadmap while introducing the data, the system, the electronic or digitalized system. Otherwise, it's very challenging when you have the two systems in parallel, and it creates a lot of workload burden to the frontline services. And then it's very difficult in terms of verifying the data, because you have the two systems, which one that you refer to. And I think that's the most challenge. And I think that need to be addressed from the beginning in terms of policy development and getting the commitment from the national TB program on that. Oh.
Yeah, and Dr. Song, just there is also a question from Job Alele, which is that how did the double entry of cases from paper and electronic systems handled at the national level for proper planning of the program? I think in Cambodia, you have this pilot area where the health facilities are also transitioned to electronic system. Would you like to please throw some light on that one? that how did you reduce or eliminate this double entry of data in those health facilities?
Thank you very much, Derek. I think so far, TBD also introduced what we call data quality audit, and I think that's very important that each of the health facility, each of the OD level, they review their data, and then in terms of quality, and then they can cross-check as well. I think this is very important. Second point is that when patients are registered, and the ODTB officer, which the one who verifies the patient, from health and from health center underneath them, and that officer is to ensure that there is no duplication of either the patient are referred from each other. So I think that's the system that we have. Over.
Thank you. And there is one question from Azim Timimi, which is that whether STEP covers the tension between wanting to have a system that help manage patient care and wanting a simpler system purely for surveillance, and how the STEP covers that. And that's where, the beauty of the STEP is that it's not starting with a preconceived idea that we want to do this. It starts with the overall landscape analysis and engaging stakeholders to come up with the gap in the country, and also understand the country context as well as country's capabilities to implement the solutions. So the STEP is very contextualized to the country situation. And so if the country decides to go for patient management care or digitize the patient management care information system, then they have to think in those lines. And if they just want to go for a very simple surveillance system, they can go for that. But as we see that gradually globally we see that there is a change, or there is a move towards total digital transformation. So even if a country starts with a more simpler solution, they can target or keep as a long-term goal for this the case-based digital surveillance system as an end goal of the digitization transformation. And STEP helps that in understanding, like what Meredith presented, the different domains are necessary to be considered, as well as what Yanira presented in terms of the costing. And this costing tool provides all the different cost elements necessary for this transformation, including not just ICT solutions, but governance, infrastructure, capacity building, and so forth. So that's how this STEP is very adaptable to the country situation. Thanks.
Great, thank you, everyone. I think we are running up against our time now, so we're going to go ahead and end the webinar. But again, please reach out via email so we can continue the conversation. And we will be sending out this recording along with the PowerPoint slides. Have a wonderful day and evening. Thank you, everyone.
Thank you and goodbye.
Thanks.